From Stanford with a degree in human biology, attended Georgetown University School of Medicine, completed a residency in internal medicine at Stanford, and then obtained subspecialty training in ID at the UW. He joined the UW faculty in 2005, and in 2009, launched Washington State's first Project ECHO program outside of New Mexico, expanding telehealth access for clinicians serving rural and underserved communities, and later received the Warren Reed Award and the Washington State Medical Association's Grassroots Advocate Award for his leadership in telemedicine and policy advocacy. As Chief Digital Health Officer, he leads virtual care delivery and is developing a bona fide digital front door to integrate UW Medicine's digital tools into a streamlined single sign-on platform. Dr. Crystal Wong is a family doctor and associate chief digital health officer for UW Medicine. After receiving her MD from the University of Michigan, Dr. Wong completed residency and a chief residency at the UW Department of Family Medicine. After residency, she helped open the UW Primary Care Ravenna Clinic, where she's practiced full spectrum family medicine since 2011. And Dr. Wong is passionate about providing high quality healthcare that is patient-centered and innovative. She has held positions as clinic medical director for UW Primary Care Ravenna and then associate medical director for the central region at UW Primary Care prior to stepping into the role in the health office. So please join me in welcoming both of them.
Thanks for having us. Hope that today's session is informative and practical, and would recommend that you put lots of questions in the chat. Jen will watch that for me and ping us. Thanks for nice intros. So this is what John and I have for you today. We're going to give you kind of a overview of what's going on in digital health at UW Medicine, including how our department supports the greater UW Medicine mission. We're going to go through a little bit of just like terminology, because I think there's like a lot of terminology and interchangeable terms, just so we're all on the same page. Then we're gonna actually, I'm gonna change the bullet points. We're gonna talk about digital health and rural transformation, which I think a lot of you guys have been thinking about, hearing about the money that the state of Washington got from the federal government, even hearing about how that's getting applied at UW. And then we're going to dive into the two programs that the Digital Health Office is going to be setting up for the RHTP in detail, which is Project ECHO and ECHO. And then we have some little tidbits along the way about some research studies and such that we're going to be showing. Okay, so this is kind of the slide that we use a lot, and we're just trying to let people know like what the heck is the Digital Health Office, what do here so I can read the tiny print. But as John mentioned, our scope is kind of divided into these things we like to define as probably the most obvious that you guys understand, which is virtual care. How do we either take things that are delivered traditionally in person and digitize them? How do we offer new services that wouldn't be available without digital means, et cetera? As John mentioned, the digital front door, which is just, in this day and age, everyone wants a digital first touch, right? No one wants to jump on a phone call as their first, point of entry, everything, appointments online, et cetera. So how do we synchronize all of our tools together to give patients like a good experience? And I know as primary care doctors, you're acutely aware that we have lots of divergent, disparate, siloed things, and part of our big job in primary care is coordination of care and helping patients navigate the crazy world. We also are getting more and more involved in patient engagement and education. So this would be how do you pull your patient into their health care with things other than sitting them down in a visit and writing out a list of 3 things. So how do we create tools that could integrate into their day-to-day lives that they can use at home, that fit into their work-life balance, and their needs outside of just what we find with you. And then we're also expanding our footprint. Project ECHO is kind of our biggest product in this area of clinician, and that's a large component of why we're going to be partnering with the state of Washington. When we were kind of designing our own individual or personal relations with digital health office, we didn't want to create anything that was like disparate for what UW could. So really our mission is to support the UW medicine mission through integration and establishing of appropriate digital tools that actually solve problems that are identified that our communities, our systems. And I think, if you just look at the 3 bullet points on the left-hand side, we're really looking for a patient-centered experience that is seamless, less of these fits and starts, jump out here, go there, call the phone number, et cetera. Obviously, innovative and high-value care, in this day and age where healthcare reimbursement is not what it was, this day and age where you're getting lived by payers, by whatnot. We need to make sure that everything we're putting in front of patients is high value. And then we're really interested in increasing healthcare disparities with digital tools. I think on the surface, a lot of times you think about digital tools and you think about how that's going to increase gaps, increase disparities, but if applied in the right way, in a thoughtful way, in an acceptable way, this can really help patients that have big barriers to healthcare, whether it's the in-person services or just not even have having that locally, or making it more affordable. There are many things that go into healthcare disparities that digital tools can apply in the right way. Move that along in the right direction. Okay. As I mentioned, we are now kind of pivoting to more looking at external partners, not just internal here at UW. Like, how do we feed and grow and maintain our system, but how can this system continue to support all of the community health centers, the community hospitals, rural providers, rural health systems, with the wealth of expertise and services we offer here. And so that's kind of been, I feel, like John, you can weigh into, like this kind of next phase of digital health expansion and innovation for UW. And there actually have been a lot of studies looking at kind of the value proposition for like small rural health systems and tapping into that. And we've been partnering with a lot of other big organizations that are very innovative in digital health. We actually just had a call with like Intermountain, which you guys might be familiar with. And their big selling point in partnering with all of these small rural hospitals is that it actually has driven up the revenue and the sustainability of those hospitals, because they're keeping care there. They're not having to transfer their patients, to a bigger system and so with their support of these digital programs, they're actually helping well-being to create a healthcare network really concerned about, rural hospitals and clinics like not being able to survive in this area. So some of the things we're looking at is how you apply digital health to avoid unnecessary patient transfers. I think personally, John has a lot of stories. It's the saddest thing to have a patient transfer all the way here and us to be like medically for them. Like they should have just stayed at home. They should have just died at, in states. How do we support with initial patient workups, treatment plans, program follow-up? I have actually like a personal story. My friend, her mom was diagnosed with a cancer. They didn't want to come. Seattle wanted to for their which is great. They did all the workup, but then they needed more. She ended up having to come here anyways and repeat all the procedures. That's just like so horrible for patients. As I mentioned, increasing the utilization of local care services and sustaining those kind of economies there. We've already mentioned the inpatient aspects. And then, really like building what feels as personal as possible relationships. And that's actually some of what we're needing the funding for our RHC is to actually build out like a staff network that actually has this real relationship and dynamic with the, systems or clinics that we want to reach out. So let's talk a little bit about just definitions and words so that we're on the same page as we kind of dig in. So this is kind of how we like to break up the services or the tools that we have. So I think probably the easiest to digest is what we call live video, synchronous capabilities. So that would be telemedicine, probably that's the biggest example that everyone's done. And these can be accessed through different ways. So they can be on demand. So virtual primary care, I think we were like chit-chatting about virtual primary care a bit beforehand, but that's the UW medicine service line that allows the patient to just like jump in line, get a telemedicine visit, take care of their UTI, whatever simple thing like right there. Then there's scheduled telemedicine, which I think all of you guys have some of this on your template. Patients that would prefer to, be able to move in from home, from work or something. And we also have some existing partner programs that do this kind of ad hoc telemedicine. So this would be like telestroke. So our stroke neurologists would get inputs from the hospitals that we support, can help with care planning, and then if needed, they can do like a telemedicine visit, like should that be necessary because of the then there's asynchronous care, and this is actually where we've had a lot of growth recently. I think you guys are all familiar with our internal consult program. It's really kind of blossomed internally, and we're looking to apply that outside. But there are other store and forward or asynchronous technologies that we're kind of getting more and more ingrained into our system. So one would be visit. If you guys have had patients visit, it's basically a survey the patient can, or a questionnaire they can fill out, and they can actually get medical care based on the questionnaire results. The first one we had at UW Medicine was actually COVID therapeutics. So during the pandemic, we turned that on. They would put in their symptoms, medication list, etc., and then a team of nurse practitioners could answer it and send out scripts for passing. So that's kind of been transitioned into a greater visit branch of virtual primary care they handle this now. One area that we haven't gotten into, but we're really interested in, is this idea of a virtual second opinion. Like I said, we have like world-class experts here. What about that patient who lives across the country who would like, this very highly specific provider knows about their condition? Can they just package up their stuff, send it in an electronic bundle, have the specialist do the chart review with the images, et cetera, and give them a second opinion. So that's something that we're interested in. I think we can kind of limited by one like gaming for that and all the platforms. Remote patient monitoring, and I know we are doing this more and more in our clinics. I mean, if you send a patient home with a blood pressure cuff and you want them to check it at home and you want them to send it to you, that's remote patient monitoring. It just may be very casual or like, not recorded or, maybe not billable in the way you're doing it, but we're doing more and more of that. And there's really good evidence showing like improved outcomes, especially use cases. And some of it has become standard care. I mean, I think all of us need to go, right? For someone, especially people that are on insulin, the capability that there is kind of like lots of talk about bigger remote patient monitoring programs like hospital at home, which kind of got its inception in the pandemic for a variety of complex reasons that I'd be happy to talk to you about later. We haven't done that at UW yet, but that there are ways to kind of move high acuity care into remote patient monitoring programs. And then lastly, patient engagement. So here are the tools that we have active. So maybe some of your patients are using Care Companion. I don't know how many of you guys have heard about that. Probably the biggest one we have is the prenatal care companion. So you can sign that. So when you prenatal care, you can have all of the visits in references and education sheets and stuff. There's also some specialty specific. So for instance, if your patient comes here and gets to get the total joint care companion, and it's really kind of like feeding patients like time dedication, timed instruction. There's even places for like escalations and check-ins. So like the post-surgical ones, they get a push like, "How are you feeling today?" And they can put it together. Got it. So we're getting more and more requests for communities. Digital questionnaires, those are like everywhere, right? I mean, your patients are getting them to get a Medicare wellness with you, they have depression, or they just exist and they need their depression screening. And an area where we're kind of partnering in specific areas is around digital navigation, because we know if patients don't understand how to use these tools, we're not going to get anywhere. So, for instance, the digital health office is working with our group pediatrics for a gift, I think, from a donor set of programs. So Rachel Abrams is our program manager for children's programs that connect to kind of look at some of our patient-facing resources, make them a little patient-friendly, and target maybe areas where we don't have good support materials, like my chart navigation and that kind of stuff. So we're kind of delving into that. But anything that came through chat or anything. All right, so I'm actually gonna skip to this, and then we're gonna go back to Project Echo. Here, so, sorry. So John, you're just gonna go right words.
Okay.
Project Echo, sorry.
Yeah, so Crystal mentioned the Rural Health Transformation Program. This is a result of HR1, which I think many of you know. This is where we're going to cut quite a bit from Medicaid, and so maybe this is the one silver lining from that bill. So $50 billion were allocated. Each state was, on average, going to get $1 billion over 5 years. The state of Washington got $181 million per year, and we were part of the process giving ideas to the state. And fortunately, we were selected kind of on a fast track to expand Project Echo and expand eConsult. The other project that's relevant to the Department of Family Medicine is expansion of family medicine residency network. So I think they're getting around $6 million to expand that program. And then we're getting over $6 million for these two programs. This is just year one. And we'll talk a little bit about what Project Echo is. First of all, we're not doing echocardiograms. ECHO is an acronym for Extension for Community Health Outcomes. And what we're trying to do is, first of all, offer more content, so more clinical areas. So we're expanding into cardio-renal metabolic. That's going to be diabetes, hypertension, hyperlipidemia, stroke prevention, CAD. And Dr. Eugene Yang, who's a preventive cardiologist, is going to be leading that. The second program that we're expanding into is in chronic respiratory disease. So that's COPD, asthma, and interstitial lung disease. Dr. Garbo Mack in pulmonary is going to be leading that. And then the third is in tuberculosis. We have had that kind of off and on. We're pursuing that program. So the second pillar of the ECHO expansion is to try to get into more parts of the state. We have ECHO deserts, the parts of the state that really don't have that much participation. So north central Washington, talking north of I-90 up to the Canadian border, really doesn't have that much participation. And then southeastern Washington, a little bit out on the coast too. So if you have friends, if there's anyone online who has contacts, please let us know. We'd love to reach out to your contacts and we'll be interested. I think the most exciting part is really the infrastructure that we're going to be building for Project Echo. So I started this program in 2008, and it was really kind of grant to grant. And so each division and department kind of was doing its own thing. And so we don't necessarily have a consistent product across UW, and also we don't have the most efficient system. So we're trying to kind of centralize this a little bit more. One big thing is having a better and more useful website, and was getting more support for folks on that. So that's year one of the expansion. We anticipate we'll add more content areas in future years. The second area we are expanding is eConsult. That's the asynchronous program that we started in 2018 internally, and this will be offered externally. And the three areas that we're piloting are infectious diseases, dermatology, and neurology. And we got our first partner signed up. Getting lots of interest from other health systems and practices. And another key part of that will be setting up an infrastructure for the technology in particular. I think we're going to use Epic Care Link, but we'll need some staff to support that as well. And then I mentioned the Department of Family Medicine. So let me go back a little bit and talk a little bit about Project Echo.
Do you want me to click that for you?
No, I got it. So Project Echo was started in 2004 by my colleague at the University of New Mexico, Dr. Sanjeev Arora. Sanjeev is a GI hepatologist, and back in 2004, we had a new medication for hepatitis C called PEG interferon, and it had improved some cure rates from approximately 20% all the way up to 50%, but it's a pretty toxic treatment, and so even what he was finding is that unless you lived in Albuquerque, you really didn't have access to this potentially life-saving medication. And so he came up with this idea to safely and effectively treat chronic complex diseases like hepatitis C. I was fortunate enough to hear him speak on literally it was a dark and rainy night in 2007. I heard about it. It was one of those kind of epiphanies. At the time I was kind of on a research scientist track, doing more lab-based stuff. I said, I want to do this. And he was very kind, and we wrote a grant together. And it's been really fun, and it kind of really changed my career trajectory. So the simple way of explaining what ECHO is, it's kind of like morning report. So if you guys remember when you're doing the training, or if there's still trainees on the call, you'd stay up all night and admit, back in my day it was 10 or 20 patients. And then the next day, around 10 o'clock in the morning, after you had rounded on your team, you and your colleagues would get in a room and you'd kind of card flip. You kind of go through your cases. You got feedback from your colleagues, and then of course you had the attendings in the background who would help you and kind of think about those cases. So it's very familiar to, I think, to a lot of us in our medical training. So typically we do this once a week. We like to do it at the same time. A lot of these are during the lunch hour because our participants are often federally qualified health centers are really under quite a bit of demand to see a lot of patients. And so that's one of the things we've done a lot of our programming. We ask that the local primary care providers fill out a 1 or 2 page form ahead of time. These are usually labs, meds, things like that. And sometimes the staff fills it out. And that way, the folks who are facilitating the discussion kind of know what it's going to be about, and if there's any teaching points, we can have those queued up. We typically start off ECHO with a 10 to 15 minute didactic. These are not big academic presentations with pathways and getting into molecular biology. We like to say this is news you can use. And we try to make it really, really practical. Even getting down to like, okay, this is how you get through the prior authorization process, or this is the lab order that you need to submit for this particular test. And there's a little bit of Q&A after that. I think the key thing that's different about this is that even if you're not presenting, or none of your PCP who has a case, you're listening to your colleagues presenting it, and kind of common things occur commonly. So even if you're not actually presenting a case, you can learn from your colleagues. So in addition to having an expert in the area like hepatitis C, we often have folks who are they're involved in the care of that patient. So in hepatitis C, I'm an infectious disease, but I have a board certified hepatologist, Dr. Erin Cleveland. So if they get, they've got the end-stage liver disease or liver cancer, she can really help out with that. And then we have folks who are experts in addiction medicine and psychiatry. So they get a comprehensive opinion on that one patient, and we really try not to contradict each other with those opinions. So one of the really exciting things that happens is what we call the learning loop. And this is where sometimes some of the best suggestions don't come from the UW, they actually come from folks out in the community because they know what it's like to practice in more resource limited settings and can really come up with some great ideas. So one of the mottos we have is an all teach, all learn kind of attitude. We write the recommendations, and that then gets back to the folks who asked for the case to be discussed. And of course, this has been vetted by our legal, and all those kind of disclaimers. There's other really valuable resources. We have links to maybe latest guidelines, things with prior authorizations. So there's a lot of other resources that are included in our weekly newsletter. There are 4 key pillars that are kind of the secret sauce for Project Echo. And the first is in the lower left, case-based learning. And we know this is important because this is how most adults learn best. So you have to kind of have a tangible example to hang some of the concepts on. And as I said, it's not just one person who's presenting, everyone's kind of helping it. We're also using technology to leverage scarce resources. I think in this day of Zoom, that sounds pretty obvious, but back in 2008, Zoom was not even an idea in Eric Yuan's mind. It turns out that was really one of the most expensive things when I started. We spent over $500,000 on a server downtown Seattle, and the technology was a little glitchy. But this has been spread throughout the United States and all over the world based on some of the advances in technology. We're also using best practices. So we really try to use, whenever possible, specialty specific guidelines and national bodies that are creating out best practices. The last point about ECHO is that we're monitoring our outcomes. We want to make sure that we're delivering on the promise. And so there's been lots of publications on ECHO and pathogens. So just to give you an idea of where ECHO is, it's on pretty much every continent except for Antarctica. I was privileged to help start the first ECHO in Namibia back in 2015. And it has really taken off in the continent of Africa, and also did a sabbatical in Brisbane, Australia, and they're going gangbusters there. So I wanted to talk a little bit about some of the evidence base for Project ECHO. And from the University of Washington, we had over a dozen studies across all the different ECHOs. There's 700 different publications. Many of the initial publications were looking at surveys of providers, and it doesn't matter what the ECHO is, we kind of see consistently that providers say they are getting more enjoyment in their work, they're getting mastery, and they feel like they're helping their patients. And so the other paper that I want to make sure you all know about is in 2011. Dr. Arora compared Project ECHO to his own academic practice in Albuquerque. And this is for hepatitis C back in the interferon era. The cure rate was exactly the same, and the adverse event rate was half in ECHO as it was in Albuquerque. And I think it was kind of an interesting finding. And when we kind of asked people about that, they said, well, if you're working in a rural or a smaller community, you run into your patients at the grocery store, and you can see they're not doing well, and it's just a little bit easier to keep track of them. So I wanted to talk about some of the studies that we've done here at the University of Washington. These are both from our HIV ECHO, which is every Thursdays if you're interested. Dr. Brian Wood leads that. This first was looking at the care of HIV during pregnancy. So as many of you know, if you really need to kind of work with the hospital and a lot of times it's not OB/GYN, it's actually family medicine that are delivering these these babies who are to infected women. And so they said that they had really a profound impact, 100%. So this influenced patient care significantly. And it really helped them to manage not just their own cases, but help with their colleagues. So almost a third said without echo, they would have had to refer out. So again, getting back to one of the things that Crystal made the point on is that with a lot of telemedicine, we're just trying to keep as much care locally. And then PrEP is another tool that we have in our infectious disease armamentarium. So those are ever changing, and with long-acting injectables now on the armamentarium, this is really relevant. So over 90% that are staying up to date on some of the national guidelines for PrEP, and they're more likely to offer PrEP to the patients who are at risk. And they can likewise be a resource to their colleagues. So this next study, I think, is a really important one, and it shows the population health benefits of Project ECHO. So again, Brian Wood published this paper a couple of years ago, and he partnered with the Department of Health to figure out where patients had detectable viral load. There's this whole concept of the community viral load. And if you suppress the virus in a patient, they're not going to transmit it. So they had a lot of data on individual patients. And they found that there was an increase in viral load suppression in those patients who participated in ECHO. And the interesting thing was that the biggest delta, the biggest change was for those providers who only had like a handful of patients with HIV, so 3 to 5 patients. And there was a dose effect. So the more times you came to Project ECHO, you're more likely to get viral suppression in your patients. We found that after participation in ECHO, the viral load suppression improved. This last issue, the last point here, was really important, and it shows that even those providers who were not participating in ECHO, but if they had someone in their clinic who was, they also benefited. It kind of showed the teaching that happens within a clinic. So I think we'll turn it over to Crystal to wrap us up with e-consult.
Yeah, so going back to the rural health slide with the 3 buckets, the other bucket that we're spending money on is external e-consults. So currently, I'm sure all of you guys have used our internal e-consult program. It's super slick. Just put an order in Epic, get a response in 3 business days, which is like insane, like unheard of, to get a neurologist to answer your question in 3 days as opposed to a patient waiting 9 months to get an appointment. It's amazing. And we want to do this externally. The biggest thing we're going to run into though is digital platform, because there's like EHR interoperability is like non-existent. Maybe even maybe read only is getting better, but only really because people are jumping on Epic more and more. That being said, I think care everywhere is kind of gnarly sometimes too. But we're going to be trying to offer our services to that one provider in a solo practice who's still on paper charts. Like, how are we going to, get grant access to this? So, you guys might be familiar with. Have any of you guys used the Seattle Children's e-consult platform? Yeah. So that's what we're going to do. I'm a little bit scared as someone who's going to have to organize this, but they basically have an open platform. You have to get security, a secure login. You do have to be responsible for uploading all of the material that specialist needs to give you a good consult. I have no idea what we're going to do for image viewing. Like John said, we're going to do neurology. You can bet that neurologists want to look at that MRI. So I've got a laundry list that I feel like grows by like 30 tasks every single day of things that we're going to take a village to try to set up. But that's really what we're looking for. We are going to start with some specific organizations. We're actually just asking for volunteers. John's been going to the Rural Health Collaborative and trying to sell our services on them. I think the biggest thing that I want to emphasize to, all of these practitioners who are trying to help is that this is a free program. I mean, we will bill insurance because we are required to, but you don't have to pay for this platform. Many of our colleagues that are working rural health systems are paying subscription fees to access econs. And this is going to be open. That does put some complexities on us. Like, we're going to have to capture guarantor accounts and insurance, and like, that's why we need staff to work on those things. But, this is really kind of a mission-oriented program to have our specialists be able to reach anyone anywhere in the state of Washington. Plan, we get money, John, more money to continue to expand to more and more specialists. And I think the big key thing, and again, I'm also happy to hear feedback about our internal program afterwards. I know we've had, there's complexities there. There's like funding issues and things like that I think have sometimes led to inconvenience. But the biggest thing and the game changer for this is we're actually getting money to pay for FTE. So we're going to get to pay a specialist to actually sit down, only work this. They're not going to be thinking about, I'm on call at the hospital and I'm doing e-consult, or I'm in ambulatory clinic and I'm doing e-consult, or I am on call this whole week and I get to do the e-consult. This is time that the specialist will get to relationship build, educate, provide excellent services, develop really great relationships with providers and build trust. We're really excited to do this. I think there's going to be a lot of learning. I think this group is very familiar with the nuts and bolts of e-consults. I'm not going to dwell that long on it, but some areas of enhancement. So e-consult is like a well of information. Like, we have done 50,000 now, John. 50,000. There's so much information in that there's so much, best practice guidelines, tailored instructions. Like, how can we use that wealth of information and create something that you can tap into? So that's really something we're really interested in. I know we've had maybe some leads here and there with some of the like AI computer science people. We don't have anything solid, but we're trying to figure out how to tap into that for education. We are looking at kind of streamlining the way we do healthcare in the academic medical system as well. Like, one of the key areas of, I guess maybe like e-consult trends, because we're doing a lot of specialty to specialty e-consult. Like, we just turned on, right, FHCC oncology ortho. Like, what is that? It's like someone having musculoskeletal stuff who's the onc patient, and they would like curbside ortho, and now they can do it. Or we just turned on oncology pain. So instead of sending the onc patient having pain crisis to ER, they get to do this e-consult pain. Put in some recommendation for medicine and such. So we're doing a lot of those types of things, investing. I think the next wild frontier, both internally and externally too, is inpatient e-consult, which is a little scary. I fielded a call from CT surgery about 6 months ago about turning on CT surgery with patient e-consult, and I said, okay, excuse me, ECMO e-consult. Let me talk to some other people about this. But, I think we do a lot of this kind of curbside communication, which is great. I think a lot of us maybe get like a lot of epic chats now with maybe like scary or maybe inappropriate things that shouldn't be in like a chat. But how do you formalize that so you get an actual recommendation that's like in the chart, you can reference it, bad happens, or management's not freaking out, and maybe it's billable too. That's always kind of great. So, we're looking at that. Another thing, and actually we're having discussions with the Department of Dermatology, and many academic institutions actually pivoting to this, and this is what's called a reverse e-consult. So this means everything comes through e-consult. The specialists, all the specialists that do member review for us now, they look at it and they say, I can answer this as an e-consult. They send you the answer. Nope, I can't do that. This goes to scheduling. So Stanford has a really big program. I think Durham is trying to do what University of Rochester did. They did basically complete reverse e-consult for dermatology. So we're looking into this. Again, some of the technical tools are just like not awesome yet in Epic. It's very challenging to flip from one modality to another. I mean, you guys have probably just experienced this in real life, right? Let's say you get a MyChart message, you're like, oh shoot, I should probably just see this person. Like, wouldn't it be awesome if I could just like do a telemedicine now, or something like that? The EHR doesn't work like that right now. You have to back out, right? I mean, it's exactly like BPC. I don't know if any of your BPC versions you want representative use. They respond to the patient, hey, maybe you should consider BPC. You can get your answer right now. What you need to do is back up, go to this menu in Epic, click this button, and then get in line, right? What if there was a way to just send that patient to BPC from there, as opposed to having to send them like 4 instructions to follow? So those are some of the things that we are doing internal advocacy with Epic on, we exist in a spectrum of care, a continuum of care, and the EHR needs to be able to support those care transitions. But anyway, so we're looking at that with what tools we have. Okay. So I thought I'd share a little bit of some of the evidence behind e-consult. I thought this article made me laugh, because how many of you were around when DC Dugdale would randomly look at a patient you had with hypertension and do this like unsolicited e-consult and send you a staff message and be like, Crystal, you should add on this medicine or do this combo, and you're like, what? DC? At least I know who you are, but what if you didn't know who we were? Who is this random internist like telling me to up my lisinopril or something? But this is what Mass General did. They looked at patients with diabetes who had a A1C trigger that fired a automatic e-consult, and the endocrinologist would look at it. They would do the screening e-consult. They'd send you a completed e-consult that said, please start a GLP, and people were like, what the heck, what's a GLP? Or do this or do that, and they looked at outcomes. Interestingly, no surprise to me, I guess, people didn't follow their recommendations. They had 30% of people actually implemented what the endocrinologist said, but they did look at this population. It did see these providers seem more open to using some of the newer medication in practice. Maybe not in that specific person, but in their practices. And I know, especially with these meds that seem to change all the time and are super expensive, and their names are all very weird. And somehow my patients know about them and I don't know about them. It can be helpful, right? Just getting. But I think that this is maybe just a good illustration of the fact that e-consults need to be applied wisely in the right scenario with buy-in and communication and relationships. And you should probably know who that specialist is that is giving you this recommendation. Trust building, and what speaks to primary care physicians. And we're hoping that we do better than this study. So the last thing I just wanted to show you is, again, in talking about continuums and spectrums, what would be John and I's final destination? What would we love to set up? And we would love to set up this kind of ecosystem where you could funnel through and get your needs met without backing up, needing to know about the special program, et cetera. And so, when we're just talking about supporting rural providers, one of the things that we're hoping to set up is this ability to, have a Project Echo where you're doing case-based learning, where if you have something complex you can present it, where you're learning from your peers, where you're participating, and then your general comfort in managing some of these complex conditions where maybe you have poor access to specialists or not a lot of community resources, that baseline comes up. Then, should you actually want care for a patient or need a specific recommendation, then you can put in that e-consult. Let's give you some specific recommendations. Let's look at the patient PHR. And then, we'll have phone consults available, because I think, how many of you guys do MedCon, even though we work here literally. So MedCon, right, was phone line to ask any specialist, loved by the community, hated by specialists, is now gone and still lives in UW Medicine legend. But how do we create something like MedCon where it's just I just really don't know what to do, does a person need to go to the ER? Does a person need to consult? Like, what can I do? So we want to be able to resurrect that in a way that's sustainable for a specialist. And then, even be able to offer that direct to patient or provider telemedicine, whichever, suits him needs, needs, and just basically allow patients kind of, and providers will go along the spectrum as opposed to have to touch together. So that is the vision. Has to be in 5 years whether we achieved it. We also need to figure out a way to make this financially sustainable, not based on grant money, but we'll just figure that out. So that's what we have for you, a formal information. We'd be happy to field any questions.
Thank you for all the work you all have done in bringing medical care to the masses through these modalities. I had to ask about artificial intelligence. You mentioned it one time, Crystal, and this has been my question for every talk over the last 2 months. So, but that is obviously the new frontier. If it's not already here, not only can my consult be done through open evidence, my chart can be reviewed, my best practices can be suggested, my therapeutics that are lacking can be, shown to me the electronic health record. I mean, there's even companies, as Misbah Keen reminds us, like Lotus.ai, based out of San Francisco, which is venture capital funded, that is providing free primary care through AI, full stop. What are we doing to leverage some of these technologies in the digital health realm?
I'd be happy to take a stab at it, Nelson. So I actually just came from all-day Epic IT retreat, and we were talking about AI quite a bit, and we saw what Epic has in the pipeline. So there are 15,000, just give you an idea of how much resources Epic is dedicating to this, Nelson. There are 15,000 employees at Epic, 6,000 are working on some kind of AI tool. The discussion was along the lines of how are we prioritizing AI tools and making sure that we're getting the biggest bang for the buck. So looking at ROI, looking at, how is this improving clinical care, improving safety, things like that. And then the other thing is, how are we training our providers on these AI tools? So I'll just share something that happened earlier this week. So we had our AID division retreat, and I was talking with one of my colleagues who he's like the smartest guy in our division, and we were talking about AI, and I said, hey, do you know about open evidence or UW chat? He's like, no, I've never used it. So, I mean, the fact that like the smartest guy in my division doesn't know about this, and I mean, as smart as he is, the fact that he didn't know about it is a real missed opportunity.
That's shocking to me.
It's shocking. It really is. But if you look at adoption of open evidence, it's around 50%. If you did a survey, and I agree with you, it's transformed my practice too. So a lot of this work is being run through the Innovation Core. You guys heard of that? No, not so many. So Anna Anderson is leading that, and we're really I'm part of that group where we're trying to prioritize AI projects and making sure that that there's not going to be any data security, safety issues, but also just not overwhelming people. So I saw 200 new AI tools from Epic. And we just don't know like which one is like we're probably going to start with 5, right? But what are those 5 high yield ones? That is the work that all of us are going to have to do. So I don't know if I answered your question, but we're thinking about it. We're trying to have governance around it, trying to be really strategic about what we do and what we don't do, because we can't do everything.
I hope our circumspection doesn't cause us to be too slow of adopters.
100%, yeah, 100%. And I don't know if you guys are kind of on the AI, chat boards and things like that. there was an article last week published in Science that looked at AI performing against master clinicians on some of the New England Journal of Medicine CBCs. And guess what? AI like kicked the butt of the clinicians. And this is different from passing the boards or things like that. These are actual cases. So what I'm seeing is the conversation is changing from how's AI gonna help me to is AI gonna actually replace us? And I think we need to really confront that question and not have our head in the sand. We don't want to be Blockbuster. We don't want to be the New York City taxi medallions and get replaced by Netflix or Uber or the equivalent. The good thing we have going for us, Nelson, is that we have one of the best computer science departments in the country. It's right across the street. And collaborations with some of those folks, I think there's a lot of opportunities. But we really have to pay attention. This is going to be the trend that defines our whole careers.
There's a question from Emily Godfrey for John. Can you talk more about how groups for echo specialties are chosen? I'm interested in hearing more about the echo led by cardiology.
Yeah. So historically, it was a faculty member who had some interest and found some funding. I mean, we've had some funny ones through the years, and some of them are no longer operational. But the way that we chose the new ones, and we actually have this all written down. We looked at the top 10 causes of death in Washington, and we tried to map the cause of death to do we have an echo in that. And that's why we started with the cardiorenal metabolic. I mean, CAD is #1 cause of death, strokes #4, and then diabetes is in the top 10 too. So that one echo is going to get 3. COPD asthma is, I think, #5. So that's how we're really from a public health standpoint. So that's one criteria. The other criteria is linking this to the overall UW medicine strategy. Are there certain departments, divisions, procedures, quite honestly, that we're trying to drive volume towards? And then the other is if it was an echo that lost funding, like our TB echo. So those are kind of our 3 rubrics for selecting an echo. And I do want to also emphasize that this is great for our residents. So yesterday when I ran the viral hepatitis echo, we had a resident from one of the Health Point residency sites who was presenting a case, and it's really good learning for them. And I think it's great for the WAMI network as well.
I'm kind of grumpy.
Sorry, can I just ask a follow-up to that, John? Sorry, this is Emily Godfrey. I guess I'm just wondering, I guess you didn't really answer my question in terms of how people are chosen. We're a very siloed health system, and part of the mission is also to start countering that. And so I'm just wondering why we can't use echo as an opportunity for potentially different specialties to come together rather than sort of one specialty owning it over another. I mean, as you know, family medicine has many, foots in many different areas that are considered specialty areas. But I haven't really seen that family medicine is invited to the table to be part of, leading part of these echo opportunities unless we start them ourselves.
Yeah, so good point. And I would just say that we do have a primary care provider as one of our SMEs for the cardiorenal metabolic. And if you have ideas, please send them to us. So like we're kind of running a list of future echoes. This is just year 1.
Yeah, and on that, Emily, so again, we're kind of pivoting from this like my pet project grant funded echo to like the systemic structure. We're still like very early in trying to, we're going to have to do a lot of, to be honest, like best practice adoption from our existing echoes, which we've already started But as part of phase 2, which is basically expansion after these 3 echoes plus building of the infrastructure, like we're building like a better website, we're gonna house the resources all in one place, you know, CME and calendar and all that stuff that's spread all over the universe. It's gonna be centralized, but we are putting together kind of a application process that's great for people who want funding to be next for echoes. There'll be like a scoring system and like that. So you know, if you have an idea now, send it to John because we are keeping lists of people who, you know, are interested, but we're not quite ready to field the next wave yet because we need to get our feet under us, the basics first.
Can I plan an idea for a future echo that I'd love to see is women's health? And that would be,
Yeah, and I think that's one of the things, like I would put it under like best practices and reward is like, how do we make these like more like a higher utility thing as opposed to like little fractions of this? Like if you look at our echo site or like our list of echoes, we have like 1 million like psychosis ones. Like why do we have 5 psychosis echoes? I don't understand. Why don't we just have like 1 psycho? Well, why is that not just part of a greater mental health? So we're trying to like
more job.
yeah, because that is also like we need people to use these. And if I was a busy primary care doctor and I saw prenatal psychosis, what the heck? Like, why would I ever go to that one? You know, so we're trying to batch.
Okay, I have a grumpy question. And I don't think that you all did this, but this is kind of illustrative of the question that I have. So there was this campaign about blood pressure where they sent everybody this thing through my chart, and then all of a sudden you were supposed to contact your primary care doctor for help. So the information that I got as the leader of my clinic at Harborview came out like 36 hours before. They're like, by the way, we're turning this thing on. And we had no time to disseminate it. And then I can only imagine what it was like for you friends up here at Northgate, because I then received this deluge of like, oh my God, I got this thing like 4,000 extra messages from the nurse trying to, okay, so there's zero compensation for this care for primary care physicians. Like this, I did this like on the weekend for fun. It was not fun. So as you think about these things, I'm pro blood pressure control. I really am. But what are the balancing measures you consider as you have a primary care workforce that is burning out and too much pajama time? And yeah, this thing helps a little bit, but like every time you send, again, and I want people to have heart attacks or strokes. That's not what I'm saying. But who's coming to help us with these like grand ideas? And especially if the e-consult thing where you're like, well, we're just going to reverse it. It's like, how many in baskets am I going to get that then I have to work on? So whose job it is to think about, as we're doing this QI and change management, to think about the balancing measures so that there's some of us left at the end of the day. I don't know if you've heard
I like totally agree
great.
with you, Amanda. And you know, I think part of what we're trying to do is, so digital health, we don't do anything. Okay, let me just make this clear. People tell us what they want turned on. Okay, and I think what's important is the people that are asking the digital health office to do X or Y or Z, like one, are very aware and educated about what does this look like, what does it impact, and honestly, the biggest thing that I usually ask people that come to me about X or Y or Z result is, what is the problem you're trying to fix? And let's actually start there as opposed to this tool looks awesome. So what we're trying to do, and I think you guys have heard through the grapevine or other faculty meetings or something, is there's been a lot of change in like the ambulatory governance structure. And so we're trying to implant digital health into there so that those people that are leading, you know, fulfillment of ambulatory strategy, who are close to the clinicians, close to the staff, both the workflows belong to them, can, you know, be the decision makers and weigh those things. You know, Vicki, you are on the call. I know you might be eating your lunch or something, but you could also say something if you wanted to improve.
Oh, I don't think I have much to add there. Thanks.
But yeah, it's hard. And, you know, it's like, I feel like so much of medicine is just like pushing the chips around, right? As opposed to actually doing something better or doing something that beneficial. I think a lot of times we also are, don't tell my patients I said this, so patient centric that we don't really understand the implications. Like I put hospital up there. You know why we don't do hospital at home? Because it's awesome for patients, but it's horrible for the health system. It costs so much money. We'd have to like set up a whole infrastructure. Like who's going to do that work? You know, but if you ask any patient, would you like to come to the hospital and get diuresed? Would you like to stay at home and get diuresed? What are they going to choose, right? And we have to take like a measured and savvy approach to applying.
Yeah, we're out of time. On that note, thank you everyone for attending today. Remember to fill out the survey, and also we look forward to seeing everybody in June where we're going to talk about innovations in family medicine abortion care. So thank you all.
Okay. Sorry.